Okay, so thank you, Leila, and thank you, Magdi, for the invitation to come here. It's a real pleasure and honor to come here to this country. So I think we have to underscore that we all underappreciate the risk that our patients are having to die. I mean, in Paradigm, the trial which was just discussed previously, the risk was still 20% at 2 years. So 1 out of 5 of the patients sitting in your office is dead or in the hospital within 2 years. If you admit a patient and you don't do your job, the risk that that patient will die is 60% at 1 year or be back in the hospital. So what we really have to do is to try to get rid of congestion. And we have diuretics to do so. They have a class 1 recommendation, the loop diuretics, and thiazides have a class 2A recommendation in order to treat congestion. But you know that. But the problem is, how do you use them and how can you monitor what they actually are doing? The only trial that we have with regards to loop diuretics is the DOSE trial. DOSE was comparing what we all do, twice a day, the loop diuretic, continuous or bolus infusion. But the results were pretty poor. Only 1 out of 6 of these patients was dry, and 1 out of 2, 50%, was dead or back in the hospital after 2 months. So giving just a loop diuretic like we all are doing is probably not the right way to move this forward. And there are many reasons why diuretic therapy is ineffective, but we all know that if you have a patient who is already in a loop diuretic and you give him IV loop diuretic therapy, he will not respond in the way you would have liked. That is why we put forward together with Alex this consensus document a couple of years ago, how we try to improve a better utilization of loop diuretic therapy. And you can start with a high dose, don't wait for any lab result, just give it. There is no reason to wait for anything. Just give it as soon as you see the patient intravenously as a bolus and do the evaluation of the drug. If you give an antihypertensive agent, you measure blood pressure. If you give a loop diuretic, you measure urine. Either volume, which should be at least 100 cc per hour, which is very difficult to measure. Urinary volume is not so easy to measure. What is easier to measure, but what nobody is doing, is measuring the urinary quality. Measure the sodium in the urine. Take a sample, send it to the lab, it comes back, and you look at the results. What a lot of my colleagues now are doing, they're using sticks to measure chloride in a swimming pool. You can even do that in your ICU. You see a color code, and if it's not high enough because chloride tracks with sodium, you know you have to increase the dose. Is this important? Yes, it is. There are 2 studies now just presented, ENACT at HFA in Prague and PUSH-AF at ESC in Amsterdam. They both showed that if you use a natriuresis-guided approach, then you can get more sodium out and more water out with a shortening in the length of stay. Many times you see the renal function deteriorate. You see serum creatinine increase, you see GFR drop. What do? Well, first of all, you cannot interpret anything if you didn't measure the urine. Because if you see creatinine going up in the light of a good diuretic response, I don't care anymore. I just don't care. I stood here 10 years ago saying it's important that you measure that and it's always dangerous, but it's not. We know now that if your serum creatinine goes up, in the light of a good diuretic response, that you just continue your decongestive efforts. Don't care about it. However, if your diuretic response was not good, that is a patient that you need to monitor closely. Because in those, you have to rule out shock. Shock, low blood pressure, low perfusion, inotropes. But shock is rare. Only 1% has shock. Most of the times they do not have shock, but they don't respond to the diuretic agent you provided. And then you have to increase the diuretic intensity and you might have to add a second-line agent. There are 4 options. The first option is a high-dose spironolactone. Does that work? No. Spiro is really important. I give it to everybody with heart failure, everybody, unless they have hyperkalemia, but I don't use it as a decongestive agent. Athena showed that. Second, thiazides. Thiazides, you all use them. I'm sure you all use them. But there's only one trial, which is the chlorotic trial. Chlorotic showed that if you added thiazides to a loop diuretic, that you lose 1 kilogram extra over 3 days. So I'm okay that you use that, but only under 2 conditions. Measure potassium. because 50%, 1 out of 2, in the patients in chlorotic had hypokalemia, although they were in a trial. So let's think about our patients. If you don't monitor potassium, it's probably going to even be higher. And low potassium kills heart failure patients. So you should not give a thiazide long-term because it will kill patients because of ion disturbances. You can add it temporarily, but then you have to stop it once your patient is dry. What are the other two options? Well, if you look at the nephron, most of the sodium that is filtered, because you're only going to excrete 1%, so 99% of the sodium that you filter will be reabsorbed. Most of that is reabsorbed in the proximal parts of the kidney. So if you can block proximal sodium uptake, that should be a good target. And we have 2 agents that can do that. The first one, the most important one for all heart failure patients, is SGLT2 inhibition. We give it to everybody now. We don't think, we don't measure, we just give it. Does it help to decongest patients? Yeah, maybe a little bit. Maybe. 2 acute heart failure trials just presented, DAPA-RESIST, DICTATE-HF, they both showed a marginal increase in diuretic response. Not significant, but marginally. So they're important agents. I'm not saying that you should not give them, but they probably will not help you in the acute setting to decongest the patient. They are really important in the long-term trajectory for heart failure patients. So what is the fourth agent? It's the oldest one available. It's acetazolamide. It's a very old drug. We use it when we go climbing really high to protect from high altitude sickness, and it blocks carbon anhydrase in the proximal tubule. If you do that, you can double the amount of sodium that will come out. If you just give the same amount of furosemide tomorrow and you add once a day acetazolamide, 500 milligrams intravenously, the amount of sodium that will come out is double. And that's what we've tested in the AT4 trial. AT4 was a prospective, randomized, double-blind, multi-center trial done in 26 centers in Belgium, where we compared standardized loop direct therapy plus placebo versus standardized loop direct therapy plus only once daily, 500 milligrams of acetazolamide. The endpoint was, is your patient dry? I'm really dry because it's really warm here. But anyway, what is dry? Dry, in my clinical view, is no edema, no ascites, and no pleural effusion. So if there's no extravascular volume, I stop the diuretic therapy. So that was our endpoint. What was the result? Fantastic. We had a 46% increase in the number of patients that was dry at the end of the study period, which was at the morning of day 4, by just adding the cheapest diuretic agent available once daily. Now, some of you say, I don't use it, I do something else, and I also can get my patients dry before I discharge them. And I believe you, but not so much anymore, because we did the same. We let the investigators do whatever they wanted after the 4 days to get the patients dry. And at discharge, they had to report if the patient was dry, yes or no. And you see that in the acetazolamide pre-treated patients, a significant amount of patients were more dry. Again, suggesting that there was an incremental benefit of the agent over consecutive days. You could not catch up by giving only loop diuretics initially. And the reason for that is physiological. Loop diuretics induce diuretic resistance. And you see that by measuring bicarbonate levels. High bicarbonate levels, we've thought that that is metabolic alkalosis. We call it contraction alkalosis. Contraction alkalosis doesn't exist if you have heart failure. Contraction alkalosis is just a stimulus in the nephron to retain bicarbonate by neurohormonal stimulation. And you induce neurohormonal stimulation by just giving loop diuretic therapy, and you prevent that by adding this acetazolamide. The drug also works equally well in all ejection fraction categories. So have PEF, have REF, don't worry about it, just give it. And so this is my personal approach. It's my last slide. What do I do? What we do now, we're trying to promote a desalination-guided use of loop diuretics. You give the diuretic, you measure immediately how much sodium comes out. It's safe, it's reliable, it's easy obtainable, and it's cheap. It doesn't cost anything. With regards to loop diuretics, we use this natriuretic-based loop schedule. Then we switch to oral loop diuretics, and we try to discharge them with the lowest amount possible. With the proximal working agents, we give everybody acetazolamide if they are already on the loop diuretics when they enter the hospital, and we add an SGLT2 on day 2 or day 3 indefinitely, lifelong. So they are really the important drugs. Acetazolamide is a short-term acting agent, a couple of days, and then you stop it. And on the long term, that's what Alex told us, we have to increase the neurohormonal blockers. Thank you.